Dear friends, buongiorno. Good morning in South America and USA. Good afternoon in Europe. Good night in China. Welcome to the second session, second webinar of week 6. Before we start, I'd like to share with you the program of week 7. I don't know if you can exactly see my sharing. One second. Okay. Week 7, we will have different topics. It's going to be on craniofacial growth, eruption disturbances, and autotransplantation. We will have a sequence of speakers. On Monday, Dr. Perrank will talk about normal and abnormal dentofacial growth, and is just the inheritance of Bjork studies. Then Karin Bechter will talk about disturbed tooth eruption, etiology, diagnosis, and treatment. This is on Tuesday. Then on Wednesday, Dr. Turvey and Dr. Trotman will talk about facial cleft and craniofacial update on orthodontics and surgery. And we will end the week 7 with a presentation of Eva Czukowska on autotransplantation of developing premolars to the anterior maxilla, an orthodontic perspective. So without any further ado, I hand over the floor to Yves to introduce the speaker and the moderators of today.
Well, thanks, Renato. Well, ladies and gentlemen, dear colleagues, dear postdoctoral fellows, it's my great pleasure to introduce Dr. Antonino Secchi from Devon in the state of Pennsylvania, USA. Dr. Secchi is originally from Chile, but with Italian grandparents, and he came to the US and more specifically to the University of Pennsylvania to earn there his DMD, his certificate in orthodontics, and a Master of Science in Oral Biology. He taught over there for 10 years at the University of Pennsylvania, holding there the position of Clinical Assistant Professor and Clinical Director of the Department of Orthodontics. He's a diplomat of the American Board of Orthodontics, and Dr. Secchi has published in various dental and orthodontic peer-reviewed journals in the areas of treatment mechanics and straight wire appliance. By the way, he wrote the chapter Contemporary Mechanics using the straight wire appliance in the last 2 editions of the famous Graeber textbook. Dr. Secchi received the 2005 David C. Hamilton Orthodontic Research Award from the Pennsylvania Association of Orthodontists and the 2010 and 2013 Outstanding Teacher Award from the Department of Orthodontics of the University of Pennsylvania. Dr. Secchi is the founder of the Complete Clinical Orthodontics System in collaboration with Dentsply GAC and the Secchi Institute. I would like also to thank our moderators of today, my fellow countrywoman, Dr. Patricia Aubach-Dejean from Auch, France, diplomat of the European Board of Orthodontics, member of the Angle Society of Europe, and Dr. Professor Peter Naim, Branson Medal Endowed Professor in Orthodontics and Chair, West Virginia University School of Dentistry, Harvard and University of Pennsylvania grad, and diplomat of the American Board of Orthodontics from Angle East. The title of Antonino's lecture today is Class 2 Treatment, Emphasis on Diagnosis. Ladies and gentlemen, dear fellows, please welcome warmly Dr. Secchi. Antonino, we are all ears. The floor is yours.
Thank you very much, Yves.
You're welcome.
So I will share my screen now and start with the presentation. So before we start, I would like to thank Ute Schneider and Renato Cocconi for this amazing idea of putting these presentations in these difficult times where everybody's at home. I think it's a great way to share what we do and around the world. So thank you very much again for inviting me, and I hope I can share a couple of things in these amazing topics that is class 2 treatment. And I wanted to emphasize the diagnosis. So I also want to use this moment to remember one of my dear mentor, Dr. Slik van Orsdal, great professor, mentor, and friend, a member of the Anglo-Saxon Society too. He was chairman of the University of Pennsylvania for 27 years. So when people ask me, so how do you treat class 2? The answer is a little bit complex, because what are you treating, or what do you want to correct? Are we talking about increased overjet, class 2 molar relationship? Are we talking about retrognatic mandibles? Are we talking about prognatic maxilla? So we can't just say we treat class 2 with this way here. We use functionals, we use extractions, we use surgery. So I think it's confusing. Specifically today, there are so many appliance-driven orthodontics that everybody has the new gadget that is the best one to treat the class 2. But then you start using it, and for some reason it doesn't work in some cases, and you don't understand what happened. Case selection, did I miss something? So you can't put class 2 in just one big package. We need to be more accurate in defining what are we trying to achieve. So is dental, is skeletal? And if it's skeletal, how you diagnose that it's skeletal? Are we using the right tools? So also we know that class 2 by definition is a sagittal dimension. So what are the implications of the vertical dimension and the transverse dimension that is so important for us at the University of Pennsylvania in the class 2 treatment? So I want to touch a little bit upon those things too. So yesterday I was listening very carefully to Dr. O'Brien, and he mentioned some of the articles that they were published in the literature, in the Cochrane Review. And very interestingly, one of the titles was Orthodontic Treatment for Prominent Upper Front Teeth, basically overjet. And they put in parentheses class 2 malocclusion. So this is what I would treat in. I would really treat in only overjet. Are all the overjets the same? Can we treat all the overjets the same way? So I was pretty amazed by the type of research that is being done. So here, please look at these two little diagrams where I have the same overjet in these trays that I sort of, I'm showing you just one part of it. So you can have the same overjet. Even you can have the same A and B or very similar, but you can have completely different patterns that will react to your treatment completely different. Basically, you have completely different mandibles. You can have more vertical, more horizontal growers, and we need to understand this to be able to predict and also utilize the right tools for the treatment that we want. So it's not just the overjet. By just focusing on the overjet, we can miss a lot of things. Even by using the A and B, we can be completely off. So we need to see a little bit more than that. So what happened with the intracranial planes that most cephalometric analysis uses, like the Frankfurt plane or the Selanesian plane, they're very variable. So there's a lot of variability, and you can have different angles on the SNA plane or Frankfurt horizontal, and that will give you a completely different reading of how the upper and the lower jaw relates. And we use those supposedly to analyze skeletal relationship, and it can be completely off. In fact, Arnett, the famous surgeon, in 2004 published in the American Journal of Orthodontics an interesting paper where he said, look at, I have here two identical tracings, and the only difference is how angle is the Selanesian plane, and it's giving me two completely reading. One is said that the maxilla is too protruded, and the other one is saying that the mandible is retrognatic. So you can see that also can happen the same thing with planes like the Frankfurt horizontal. So what about the vertical? As I pointed out before, the vertical is really important. Angular measurements, specifically angular measurements, such as the A and B that we use every day, can be affected tremendously by the vertical dimension. remember that the angles, they open. So the more long is the face, the same angle can show that the symphysis is way more retrognatic than if the face is shorter, and you will have the same A and B. So again, is the A and B a really great tool to analyze class 2 cases? I'm not sure. I use it, but it's not just the only number that I use. In fact, I really like when it comes to cephalometrics to dig into the Bior-Jorabag analysis, because it's telling me the pattern of the patient, whether it's growing or it's not growing. It's telling me how that mandible is positioned in the face and how my treatment is going to respond to the mandible and the chin projection. In fact, I like, and we don't have time to go over the whole Jorabag analysis, but it has relationships that are very important about the mandible. And it has also relationship between the ramus of the mandible and the anterior and posterior cranial bases. Also has angles that are very interesting, that they can tell you where the mandible is positioned in the face, if it's too far back or too far forward. And what we find a lot is a lot of compensations. But we need to know if there's very well compensated naturally or if it's not. And also the lower gonial angle that I use a lot to define whether the mandible is growing vertical or not. And all of those measurements and many more that the Bior-Jorabag has, they're very helpful to understand what are you dealing with. I mean, imagine comparing this to just, let's say, the Steiner analysis, where the only thing that you have is just the A and B. I mean, the A and B really doesn't tell you anything. In fact, the patient that I'm showing you right now, the cephalometric that you're seeing, is based on Jorabag, a beautiful mandible. Is a class 1 patient, and the A and B is 7. So if I have to do a research using A and B, I'm going to put those cases into the class 2, while those are really class 1 with very good mandibles. So having said that, let me start showing you some cases where we can see some of the ways that I use to correct class 2 in different type of patients again. So let me start with this kid, 12 years old, carthric, and you can see it's more like a brachiocephalic face, a little bit recessive chin, but really good menton. You can see it's a class 2 div 1 if you look at the intraoral views, and it's a flaring upper incisors, so that would be an increased overjet. That would be probably part of the subject of a study if you consider people with a overjet of 6-7 millimeters. But when it comes down to the cephalometrics, I will define this case a perfect class 1. I mean, the mandible is 70 millimeters, which is 1-to-1 with the anterior cranial base. I have a gray ramus, so this is a horizontal grower that every single millimeter of growth is going to go forward with a very good symphysis. So this is the case that most people are very successful treated with, let's say, any class 2 non-compliance corrector or any functional appliance. This is the case that is going to work. This is the case that basically almost anything that you do, if you do it right, is going to work. I treat these cases just with appliances. I level the curvus P in the lower jaw. So here what I'm doing is just starting with a 014 night-tie wire, central wire. I go to the 2020 Bioforce arch wire, and then when I get to the stainless steel in this particular case, I decided to put a couple of night-tie coil springs between the canine and the molar, and to level the lower occlusal plane. All these in conjunction with class 2 elastics from the upper canine to the lower second premolar. And you can see that in a couple of visits, the effect is leveling the curvus P, and now I have the occlusal plane of the upper and the lower arch very level, and the rest is just basically remove the coils, go into the working stage to finish this case. You can see here the occlusal. Yes, with the coils, I gain a little bit of a room. The molars were, I wouldn't say distalized more than 1 millimeter, but beside the rotation, a little bit of distalization plus the reverse curve. The case was corrected, and it's a good grower, so everything is in my side here. And this is the finished case. And this is 2 years post-treatment. And would it look like a big class 2 with a big overjet, and that being actually a very nice class 1 after treatment, a good grower. We knew that because we used the right tool to assess that. And you can see the ceph before and after. And this is the cephalometric before and after, which is within the norm for a brachycephalic case. What about this case, John? Little bit different, 13 years old. It's a full class 2 with a little bit of an overbite. When you see the ceph, to me, this is a class 1 skeletal. I have a great mandible. The mandible is 79 millimeters compared to the anterior cranial base that is 80, is 1-to-1 ratio. I have a ramus that is not bad, it's 49. And I have other numbers. The only number that is a little bit off is the lower gonial angle 78, that is telling you is mesocephalic to a little bit dolicho, but that's the only thing. And I decided to treat this kid many years ago using headgear. And that's the VTO. This is the superimposition with the VTO, where I kind of hold the maxilla for 1.5 years to 2 years and allow the mandible to grow and to fix this class 2, at least from the skeleton standpoint, and then use braces to class 2 elastics. So at this point, I would like to mention in this particular case a paper that it was published many years ago by the group of Iowa. And basically what this paper is saying, and there are many more that they say the same thing, is basically watch class 2 dip 1, because many of the class 2 dip 1, they have transverse discrepancies. There are many ways that we use to diagnose transverse discrepancies, but this paper is saying, please pay attention to it, because by the time you realize there is a transverse discrepancy, it's kind of late. After you correct the sagittal, you will see how big the transverse discrepancy is. So it's better to diagnose the transverse discrepancy in every single case before we start. That's why in this particular kid, before we start treatment, he was narrow in the upper jaw compared to the lower jaw. So we use an expander, as you can see over there. That's after the expansion is done. And then after the expansion is done, we just place the braces. And again, I start with a centraloid wire going to a 2020 Bioforce wire, and then in the working stage, 19x25 stainless steel to level the occlusal plane. I use again, as I said, for a few months, headgear, and then I switch to class 2 elastics, as you can see right there. Here is the final arch wire before we remove the braces, just to fine tuning the occlusion. And here's the case finish, 1 year post-treatment. That's 4 year post-treatment. And this is the extra photograph. I'm sorry that they're not so good. The kid is pointing down. I should have a better shot. And this is the cephalometrics. So I mean, he was basically, based on the A and B class 2, based on the Euroback, for me was a class 1, and so the pattern was again in our favor. And you can see the superimposition, how the maxilla was held by the headgear and the mandible grew a little bit. So different case than before, different way to treat it. So let's see now a phase 1 case and a phase 2 together. So this is Caitlin, 11 years old. As you can see, has an ectopical upper incisor and a class 2 malocclusion with crowding. So at this point, my main goal was to, of course, give her some aesthetics, because socially she had a huge problems with this type of malocclusion. And of course, if you can see the cephalometrics, again, I mean, it is, I could say, slightly vertical. When you have a lower gonial angle of 81, it's kind of in the territory of the vertical mandibles. The ramus is not very very long. So the DMB7, however, the mandible length is not bad. So what I did first, because of the transverse discrepancy, I put an expander. I expand the case, and right after the expander, I follow with a sort of a 2x4 to align the upper teeth, and you can see how it changes from here to here. And that was basically, believe it or not, only 8 weeks. And then another 8 weeks, I was in the 2020 Bioforce. That was basically the end of this phase 1. I accomplished what I wanted, which is correct the transverse dimension and give some aesthetics. And this is the upper and the lower arch after these few months of phase 1. And then after that, we waited a little bit and we start phase 2. And phase 2 was basically just full braces. Level the occlusal plane and stainless steel arch wires coordinated, and then of course some class 2 elastic. Our typical pattern is short class 2s from the upper canine to the lower second premolar if the case is a non-extraction case, like here. And then just the final arch wires were vertical elastics to get a better coupling. And we remove the braces. That's the appointment that we remove the braces. That's why the gums, they don't look that great. That's a little bit later. And this is our case within 2 years post-treatment. Here is the extraoral views post-treatment. And this is the ceph. So the mandible grew a little bit, not much. The ramus grew a little bit. So I mean, we keep the pattern. This is the pattern where absolutely you don't want to distalize because of the vertical component. And of course, in this case, you need to think twice about extractions because the Caucasian a little bit flat lips. And not a very good team, so you just need to be careful controlling the vertical in this particular case. That's the superimposition. We were able to maintain the vertical. You can see the superimposition that the y-axis is pretty much the same before and after. Anna is a completely different class, what we can call class 2. It's a class 2 with a deep overbite. 12 years old. We have these cases too, and if you can see, it's a class 2, but it's not an overbite an overjet problem. So again, I mean, how do you treat class 2? It's all depends which class 2 we're talking about. So this is a very specific class 2. When I have a 100% overbite and have a collapse of the upper and the lower arches, and in this particular case, if you can see how even the premolars are leaning in, and there's some crowding, and you can see that when Jarabak is showing us that again has a beautiful mandible, it's very long. As ramus is 49 millimeters, so it's a brachiocephalic where everything is gonna grow forward, which is very good. And the main problem in my eyes here is, of course, how the incisors are related to each other, and they are all retroclined, and that's why the overbite. So another thing that is very interesting for me is many of these cases, deep overbite, people start thinking about which teeth we should intrude. Here it's not about intrusion. We don't have to intrude the upper or the lower. We have to, just level and correct the inclination of these teeth. And that's why, as you can see, my VTO was basically just torque the upper and the lower teeth for procline and give them a normal inclination for a brachycephalic pattern. And that was basically the VTO. That was my plan. And at this point, it's interesting to notice another thing, that most of these cases that they have this class 2 end on with a lack of inclination of the incisors, they have a reduced arch perimeter. So at the what you do by proclining the upper and the lower incisors to restoring the normal inclination or torque, if you want, basically you also can increase the arch perimeter, and that's something very, very important to understand. Andrews many years ago noticed that. He says if you have a lack of inclination of the upper incisors and the lower incisors, even if the canines are too upright and you're in a class 2, if you bring everything back to a class 1 and you don't restore the inclination and the tipping of the canines and the inclination of the upper incisors, you will have spaces in the arch. So you need to do that to increase the arch perimeter and to have a good final occlusion. So and also the deep curvus P. So we need to level the curvus P, and that is due basically through the arch wire sequence. And in these very, very brachycephalic did by cases, I use a reverse curve that I do it in the 19 by 25 stainless steel arch wire. So you can level the curvus P in the lower jaw if you don't procline and you don't get the right torque in the uppers. And of course, we use class 2 elastics in these cases. Why class 2 elastic? Yesterday they mentioned it in the lecture. I mean, you can use a lot of class 2 correctors, but they will do the same. In my mind, the easiest one is the class 2 elastics. I mean, there are many appliances that they can do the same. I mean, if you're willing to pay more money for them. I mean, class 2 elastics are really easy when people understand how they work, and you have to get these kids involved in treatment. They were really great. These non-compliance appliances, I mean, if you have a non-compliance patient, I mean, make sure that you convert him in a compliance one, because maybe you can put a class 2 corrector, but he's not going to brush, he's going to break the bracket, so I mean, at the end it's the same. So we've been very successful, I guess, in most, not all, in most of the kids with these class 2 elastics. So we level the occlusal plane in the upper, we level the occlusal plane in the lower, we restore the inclination, and that's how we correct the malocclusion. So we start here with Anna with an 014 centilloid arch wire. We go to a 2020 by 04. And when we have the upper jaw level and we create like a little bit of an overjet, we start with the lower arch just for comfort. We delay that a little bit. We erase the bite in the back with some stops so she doesn't bite on the brackets. And we level the upper and the lower, and when we get to the stainless steel arch wires, at the second visit, we take the lower arch wire, stainless steel, we put some reverse curves of P, we coordinate the arch wire back again, we put the class 2 elastics, and the arch wire will level little by little the occlusal plane until it's level with the upper. We keep the class 2 elastics. We have a good inclination of the upper and the lower teeth. We have a good overbite overjet. And basically we put the final arch wire with some fine tuning things, and we took the braces off. So this is Anna after treatment is completed, 4-year post-treatment. This is Anna. You can see her profile. It's a completely different pattern than the other cases. That's the beauty of it, that not everybody's the same. And again, when you see the Ceph, I mean, the upper incisor is being in a good inclination. Some people like to say that the upper incisor should be parallel to the y-axis of rickets. I mean, so you can see it's almost there. The lower incisor is a little bit proclined. And but for a brachycephalic case, it's absolutely fine, and you can see that can be stable. Lowering sacciomandibular plane, if you use that measurement, that has to do with how high or low angle is the patient. So you can say that again, the incisor has to be 90 degrees for everyone. Absolutely not. It depends on the pattern. So that is the superimposition. If you want to see what happened in the treatment, how she grew down and forward like everybody does. Zoe. So I wanted to also show that some cases, class 2-ish or class 2, we treat them with extractions when it's appropriate. And so this is what I bring Zoe. She was a teenager, I think 12 years old. Sorry, I put the age. And she was toothy, big teeth, a little bit of an overbite, a little bit of an overjet, class 2 and on. At least this is what you see in the mouth. You can see the crowding, the arches are not really coordinated. So when you see the cephalometrics, it's a little bit of a class 2. Although the mandible is really good. It's another case that if you see the A and B, it's a class 2, the overjet may be a class 2, but the mandible, I mean, I feel very comfortable with it. It's a mandible that is in a relationship, the length of the mandible 1-to-1 with the anterior cranial base, which is great. The Ramos is 50, which is pretty good. So again, I mean, we are working with a class 2, but a very favorable pattern. And in this particular case, I just wanted to align everything without flaring too much teeth because of her chin was not very prominent. So, so I remove in this particular case the upper and lower 5, and I'm not gonna drive you to wire by wire because we don't have enough time to do that. But definitely we will go from here to the final wire, where I just reposition a couple of teeth to get a better intercuspation with some vertical elastics, and that is the final wire when I place it. And this is the day that we took the braces off, where the occlusion a little bit better. We took the braces, and this is basically 1 year post-treatment. And this is the extraoral views after treatment. So you can see the before and after for Zoe, and these are the cephalometrics, and that's the superimposition. So what about, somebody asked yesterday, I think, what about removing upper bicuspids? I don't do that very much because maybe I don't have too many of the typical patients that I would do it. But over the years, we have some patients, and I want to bring this girl here that I treated many years ago because it's a very good case to, I guess, explain what I think there are some of the ideal cases to extract the upper bicuspid. And this is a 14-year-old, pretty treated many years ago, and it's a class 2 with flare teeth with an increased overjet. Midlines are deviated. You can see here, the arches are kind of flare out, they're protruded. I'm sorry about the pictures, they're old. And why I say this is a good case? Because this, you need to reduce that overjet, but she's brachycephalic. And by moving the teeth back a little bit, I won't create any problems in the chin, or I won't be basically losing some of the aesthetics. And because this patient, by having that type of pattern, brachycephalic, with such a long mandible, I know she's gonna grow, and she has a really good chin. So right now it's not fully grown, but if it grows a little bit more, it's gonna look really good. So what are the cases that I wouldn't camouflage then with extraction of the upper bicuspid? And I've done it, but I wouldn't do it again. Those are the typical small lower jaws. I'll show you some of them. Recessive chins, where you remove two upper bicuspid and you bring the upper teeth all the way back, and then you set the patient for eventually future problems, beside the fact that the aesthetic gets even worse. So upper bicuspid, brachiocephalic, good mandibles, a little bit of an overjet. Not a lot of crowding in the lower jaw, because in this particular case, I'm gonna have to upright the lower incisors, and there's no crowding, so you can always do it by reshaping the lower arch. When these cases have a good mandible in the transverse. Here, Pretty is basically wide in the arches, so I have a lot of room to upright premolars, and that creates room to upright the incisors too. And not in every case you can do that. If you change one thing, you change everything. I mean, if the same case you have flare teeth and you have a lot of crowding, that becomes basically a completely different case. And even though we tried not to remove teeth in the lower jaw in severe brachiocephalic cases, because you all know that it's very difficult to manage that. But so again, it's a very old case. This is just one slide with the mechanics. We're closing the spaces here, trying to correct the midlines. I finished the case. As you can see there, these are very old digital pictures. Back in the days, you can see the change of the arches. I mean, very interesting. The lower, the upper premolars, the upright, the incisors upright too, without extractions. And this is the face of Pretty after treatment. I like the lips, and the lips they're very good chin, very good nasolabial angle. Nasolabial angle, as well as the mental sulcus here, very well defined. So it's a very beautiful face. You can see the Ceph before and after, and this is basically the Ceph before and after. I mean, a lot of uprighting of the incisors in the lower without extractions. You can do that only when you have a good lower jaw, and the premolars can upright. You can reshape the lower arch. Now stable, yeah. I mean, if you don't flare the teeth out, specifically the canines, the lower jaw can be stable. In this case, we didn't flare the teeth out. We upright the incisors, we upright the premolars, and things change a lot. So you can see here is the superimposition. You can see the changes. The mandible grew exactly as we predicted. Forward chin projection is pretty good. 2-year post-treatment, that's how it looks. And that's how the upper and the lower arch, they look after 2 years. So now, what about Madeline? Class 2, completely different patient here. So we have a 9-year-old, and I know it's tough when you have these 9-year-olds, and that you know, if you do the right analysis, that is going to be a surgical case. And people start saying, well, she's 9-year-old, what can I do? And maybe we can do a little bit of an orthodontics and see, you know, if it works, maybe the surgery will be a little bit less. There's not such a thing like a smaller surgery. So those are the cases where people get in trouble because they try to do things that they don't work. Here, don't even think about distalizing, using a class 2 corrector, the latest one that is available, because it's not gonna work. Or at least it's not gonna work to get a decent result. If decent means an occlusion of facial aesthetics and function and everything. So in this particular case, what can we do at this age? Definitely, we can do some orthodontics just to correct any social problems. In this case, they were not, but the upper jaw was really narrow, so I expand the upper jaw. You can always expand the upper jaw, do a couple of braces just to get some aesthetics, and then just wait until the patient grows, and then basically plan for the surgery, because there is nothing in this world that I know that is going to change that pattern that you see right there. This is a class 2 high angle case with a very, very precarious size of the lower jaw and size of the ramus. This case is not growing well, and it's not going to grow well. There's no vertical control. There's nothing that you can do in this case that is going to change the pattern. So those are the cases that you will need to identify and basically do as much as we can, solve the problems, make them happy, but explain them that, of course, in this case, I wouldn't take upper bicuspids. I've done it, and I regret that. And in this case, yes, I mean, I can fix the occlusion, no problems, but that will be just one part, and I will leave the face like it is. So you can see here, I put an expander. At that age, we expanded, we kind of correct some of the alignment in the upper jaw, but other than that, I wait. And then look at how she grew. She's now 15 years old, and those are the patterns. And of course, it didn't get better. I wasn't expecting. This is a very bad mandible. Many of these people sometimes develop joint problems. Not all, but some of them. So I mean, there's so many red flags here that, as they said yesterday, of course you need to do something, because it's an age where they don't want, you just can't tell them just wait till 15 years old and get the teeth crowded or whatever, or the overjet. You can correct certain things, but understanding that the outcome will be most likely surgical correction. So I can fix that occlusion without problems, but that was not the point of it. So I mean, I put the braces, I decompensate the case as much as I could using class 3 elastics and stripping the lower jaw. We put the surgical hooks, and she had a surgery. That's just right before the surgery. That's when she came back, and I started kind of finishing the occlusion. I have to re-expand her because it wasn't enough what I did at the beginning. And I put a tight expander over there. There are many of these devices out there, and that's how she looks when we finish the case. And that's our patient. I'm sorry. That's after the surgery. That's how she was, and that's after the surgery. So class 2s, again, not all the same. Not all the same need to be treated the same way. And I bring this Natalie here because this case is another example of you have to do the right diagnosis. I mean, I wasn't the first orthodontist who saw her, and that's why it's an interesting case. So 11 years old, class 2, lower jaw recessive, upper lip flat, nasolabial angle, really obtuse. This kid, you don't want to retract those incisors, not even 0.5 millimeter in the upper, because there's no lip support there. And the problem is definitely the lower jaw, just from the facial standpoint. Now, it is a full class 2 with an overjet. So from the occlusal standpoint, it might look like some of the other cases that I showed you before. But when you look at the cephalometrics, it's a very different one. It's a very short mandible. It's a mandible that is about it's about 8 millimeters shorter than it should be, and the ramus is not super big, so it's just not a good grower. And in fact, the first treatment that she had done was a functional appliance that didn't work. Her caused problems. Actually, she came to me because of a joint issue. 11-year-old with a click. So I told the mother, listen, I mean, this is the problem. I don't want to try to do anything right now to correct that kind of a recessive small jaw because I'm going to fail. They understood, but I still could do something for her. So having a good diagnosis for the transverse dimension, we knew that the upper jaw was narrow compared to the lower jaw. So I actually expand the upper jaw at that age. I put braces in the upper jaw to create a better round arch, give her aesthetics, and she was happy. I put her on a retainer at nighttime, a night guard. And then we waited until she grew up, and we did orthodontics, full orthodontics and surgery, and that's how we treat her. So I mean, this is our patient at the end of the treatment. She's happy. That's the extraoral view on the profile. You can see the improvement. Now, I would like to finish with this case, Patricia, 59 years old, because of all the things that we have talked, also about class 2s. Right now, there's a hot topic that is airways. And as long as your treatment doesn't damage or create conflicts with the upper airways, I think that the camouflage is good. But in this particular case, Patricia came to my office almost 60 years old because she had already diagnosed mild to moderate sleep apnea. So she kind of knew what she was going on. So I explained her that we could fix her bite, but and she was told before that probably she needed a kind of a surgical intervention. So this is what we did. So right now it's really important to pay attention to those things because if you go back to the 9-year-old kid that I just showed you, or the 11-year-old with recessive jaws and vertical jaws, those are patterns that eventually in the future, they're red flags for some sleep disorders. I'm not saying they will get them, but they're red flags. So I used to camouflage those with extractions of the upper teeth, bring back, and those are not the right cases to do that. But Patricia is an example of these corrections. So I put her on braces. Now you can see here I did an STO. You can see the pre-treatment. The blacks tracing is a short mandible. Yes, the A and B is 9, is pretty severe. But again, I mean, doesn't tell me much. I mean, what it's telling me is that the lower jaw is very short. It's almost 10 millimeters shorter than what it should be. Interestingly, so I did an STO, and based on where the teeth were, I predicted I could move them. We planned for about 5.5, 6 millimeter of advancement of the lower jaw for Patricia, and this is what we did. So I had to level and align again, then level the occlusal planes. I used class 3 elastics to create a 5.5 to 6 millimeters of overjet, so decompensate what she had. So then we have the VSSO and the mandible advance. So this is just after the surgery, and the rest was just do the final touches here, there. We typically spend between 4 and 6 months after the surgery before we can take the braces off for good. So this is just finishing. So we took the braces off. And this is 1 year post-treatment for Patricia. And this is the final result. You can see compared to the before. This is the after. And a very happy patient, and improve, of course, the upper airway function. So class 2 in summary, I mean, it is a complicated topics again, because I don't think when you say class 2, you're defining really the problem. And I think that that's why there's so many different treatment modalities, and everyone comes with the new gadgets here and there. But if you're gonna just tell me that your treatment definition is an overjet or an A and B, I think that you're calling for trouble. So my summary that I would like to share with you is class 2 malocclusion is too unspecific if you say just class 2 malocclusion. So we need a better definition or diagnosis of the problem to really understand what we have, so we can solve them with more consistency. In my opinion, overjet and A and B, they're not great indicators of the class 2 complexity. I use them, but I mean, I don't base my whole diagnosis on them. Important is to evaluate the mandible, of course, the size, position, and growth direction of the mandible. Transverse discrepancies are commonly found in class 2 malocclusion, specifically class 2 deep 1. So we need to pay attention to make a proper diagnosis of these transverse problems. And camouflage is okay for class 2 as long as facial aesthetics and airways are not compromised. So having said that, I mean, in this very short 45 minutes that I have, this is what I brought to you guys, and I hope it can help. And I'm pretty sure there's some questions, and I think that we have time to answer them. So before we go to the questions, I want to thank you again for your attention. And now we can go, Peter. If there's any question, I'd be more than glad to answer if I can.
Patricia, you should unmute.
It's okay now?
Yes.
Can you hear me, Renato? Okay.
Yes, yes.
Thank you very much, Dr. Secchi, for this great presentation with your so fantastic cases. For the moment, we have questions regarding many topics, a lot of mechanical questions, and some of them are for diagnosis. The first question which came was from the son of our friend, Dr. Joseph Bousseral. You know him very well, I'm sure. And the first question was, thank you so much, doctor, for the great presentation at first. And then how was the big protraction of the upper incisor treated in the first case? How did you gain space to retract the upper anteriors? Do you have explanation for getting place for this first case?
Yeah, so I know the case you're talking about.
It's the first one, with the proclination of the upper incisor.
So so again, I mean, this particular case, if you remember, was a brachycephalic case with really good arches. It's just that basically the malocclusion that he has tapered the arch in the front and flared them. And it's just it's a little bit of geometry. I mean, if you have an arch, if you have an arch like this or like that, if you sort of expand the arch, of course, the front part will kind of come back a little bit. Now, we don't expand the arches just dentally because that's not really stable. But his transverse discrepancy was normal. I mean, so the upper arch was pretty wide with the lower arch, brachycephalic, square face. It's just that the malocclusion tapered those teeth. So in that particular case, it was just about arch coordination and proper torque of the incisors. And that's how we actually brought those teeth back. Very similar to answer the same question, but in the lower arch, I mean, how can we, in that patient that pretty, how we upright the lower incisor so much in a case where you do extractions? And it's the same phenomenon. I mean, is that the arch is pretty wide, but the teeth are compensated forward. So as soon as you upright them, the teeth can in the front can upright. Now the trick is that you can do that in every single case. This is why you just need to analyze every case, and if you have the right arches, then you can have that sort of a response. But if you have a small upper jaw, crowded with protrusion, I mean, it's not going to happen.
Okay, thank you. It's up to you, Peter. Do you want to ask the second question?
Sure.
Peter?
Dr. Shashi, thank you for the excellent presentation, and I'm pretty sure the graduate student really appreciate, the different variety of class 2 cases that are diagnosed differently. That treat with one cookbook methodology. Now, you mentioned about the transverse dimension, which need to be addressed before you actually address the sagittal correction of class 2. Now, if a patient does not have a posterior crossbite, how do you assess or diagnose the transverse dimension and decided to do expansion prior to treating the class 2 problems?
Yes. So that's a very good question. I mean, we don't really see much whether there's a crossbite or not, because a crossbite is totally dental compensation. Let me put it in this way. You can have talking about class 2, you can have a huge sagittal skeletal discrepancy with no overjet because the teeth are compensated. Or you can have a class 1 skeletal discrepancy where the upper incisor is really far out because of a habit. So in the same way in the transverse, you can have a very narrow upper jaw compared to the lower jaw, and you don't see any crossbite because the teeth are compensated in the back. So there are many different ways that we can use to analyze that. I show a couple of PA-CEF posterior anteriors. That's the legacy of Dr. Van Arsdal that taught us how to measure the transverse discrepancy at the jaw level using a PA-CEF, and there are 4 landmarks, 2 in the upper jaw, 2 in the lower that we use, and there is a analysis that actually was developed a long time ago by Ricketts that can be used. Now, in the recent years, we've been more sophisticated, and we've been using something very similar, but even better, using CBCTs, cone beams. That, I mean, it would be another big explanation, but the main point is you have cases where there is transverse discrepancies and you don't see them because of the teeth are camouflage, and you need to have a tool to understand if there is a skeletal discrepancy between the upper and the lower jaw in the transverse.
Okay. Now, if clinicians or PA-CEF, could they just take a set of study models, study cast, and just advance the mandible to a class 1 skeletal position and just see if there is any shortage of canine width?
Absolutely. We actually do that in kids sometimes, so the parents can see with big overjet. You can tell the little kid, can you just move the lower jaw forward until the overjet is kind of soft, and you see that suddenly the teeth are in crossbite in the back. So that's another way that you can do with the models too. Absolutely. Yep.
Yes. Thank you. Patricia?
Yes, I have a question from Europe regarding width. Do you think that the evaluation with width is a good diagnostic tool?
Yes, you know what? I use it. Actually, in the CEF that I was showing there, I have a lot of numbers, and one of them is the width. I use it too. It's way better, in my opinion, than the A and B. So I use that a lot for class 3 too. I mean, when I have a width that is over 5, I mean, minus 5, I mean, it starts becoming like a scary class 3. And I like it more because is the width is working on the occlusal plane, which is basically where we as an orthodontist are working with appliances over the occlusal plane. So it's another tool that you can use. I mean, don't get me wrong. I mean, I'm just saying that I see so much A and B, specifically in research and all that. And then I think that we need to have not only the A and B, but other tools. I mean, the width is one of them, absolutely. And you can always kind of compare, okay, I have the width, I have the side of the mandible. You can go back and forth and you have a better idea of the subject that you're treating. Yeah.
And Peter, if I can do it, we have a question from regarding the prediction of the growth, of the mandibular growth. Do you have any protocol, or do you use some Bjork's signs or something to evaluate the possibility of the mandibular growth before treatment?
Yeah, well, in growing patients, the only thing that I do is I use the Bjork analysis, and I see basically how big is the mandible at that particular age. For instance, if based on Bjork, the length of the anterior cranial base should be 1:1 with the length of the mandibular length, the corpus of the mandible, by the age of 11. So if I have a 9-year-old and he's a few millimeters shorter the mandible, it's still pretty good. It's gonna grow. If he's a 9-year-old and the mandible is 10 millimeters shorter, then we're in trouble. Then also I see if the growth is more forward, kind of horizontal or vertical. So you start putting things together. I see if the saddle angle is open or is closed. Of course, the tough cases are the one that they have every single thing a little bit to the wrong side. Like the saddle angle is too open, which means the mandible is far back position, is shorter, and the ramus is short. That's the worst case.
The high angle case.
And yeah, the typical high angle, and there are not very many, but those are the ones that we is kind of for trouble. Yeah.
Yes. Especially if the class 2 is very large to correct. So with those high angle cases. So
yes.
Peter?
The first case that you presented with a large overjet, you trap a coil spring between the canine and the upper first molar. I think that's a very clever way to derotate the upper molars, which you actually can gain maybe about a couple millimeters of arch perimeter. Now, the question asked is, you run some short class 2 elastics between the upper canine and the lower premolars instead of running it to the molars. Now, has anything to do with correcting the excess curve of space?
You know what? It kind of helps, and those are one of the. I mean, those are one of the things that I got used to it just for my background, and that I learned that long class 2 elastics, they were not very good because they can actually extrude the molars, and they can sort of reposition the mandible forward like a Sunday bite. But in this particular brachycephalic cases, there's no problem if you run an elastic from the upper canine to the lower first molar. However, I mean, I got used to do it to the second premolar, but then over the years, we realized that actually when the patient's open, and there is a vertical component exactly where you want it, which is to level the curve of spin. So every time that the patient opens at the level of the premolars are coming up with the elastic, and it definitely helps you with the curve of spin. And I use that. So this is what I use it what we call the short class 2 elastics rather than long.
Yeah, there is also another question about using either bite plate or bite block,
Yes.
you know, or
Yes.
deep over bite cases. Now, first of all, do you use them? And if so, do you put it on the anterior teeth or you put it on the posterior teeth?
Yeah, you know what? These are one of the things that logic doesn't always go together with the clinic, and it definitely makes sense in deep bite cases to use an anterior bite plate to let the posterior teeth to extrude and help you with the vertical. That's why I done it. I used many times to open the bite by turbos. And then I realized that those things were kind of uncomfortable for the patient. So I switched to open the bite from the back, which is completely contradictory because you said they're going to intrude the molars, and they do a little bit. But the reverse curve P and the flattening of the occlusal planes with the arch wires overcome that. And in fact, as soon as we level the occlusal plane in these deep bite cases, we remove those stops in the back, and you can see a millimeter of opening, and then those teeth, they come back together. So right now, I don't use bite plates to open the bite in deep bite cases.
Okay, Patricia.
Yes, I have a question regarding the leveling of the curves P we were talking about. This is the main problem when you need to level these curves P with very deep bite cases, very severe deep bite cases we were talking on. So do you use always reverse curve on stainless steel, or do you use it on night eye, for example, night eye wire?
Yeah, I use it always in 19 by 25 stainless steel arch wires, and they need to be very very rigid, con a stiff arch wire. So not every stainless steel is the same. So make sure that the one that you use is very stiff. I don't use the night eye because with the night eye, I don't feel myself that I have a lot of options to customize it. So for some cases it can be too much, for some cases it can be nothing, depending on the pattern. So the stainless steel, I can actually put more or less based on what I see in the clinic. So there are very mild cases that I put a little bit of reverse curve with my fingers, put it back again. There are cases that I put a lot. There are cases that actually they're very tricky. The midline in the lower is to one side, and you realize that is because the curve of P in one side is deeper than on the other side. So I put reverse curve only in one side to level the midline and to level the occlusal plane. So I think I have more versatility when I do it myself in the stainless steel 19 by 25.
But I guess the size of your bracket is 22 by 28.
Yes, I have a 22 slot. If I had a 18 slot, I would be using probably 17 by 25, depending on the bracket that you use, or 18 by 25. And I know in Italy, I have many friends that they're bidimensional. So, I mean, I think still you can do it. I mean, you just need to, I think that the most important part of the wire is the stiffness, because that is what helps you in these really brachycephalic cases to level the occlusal plane.
Okay, and then, this is a philosophical question from a graduate student. Now, you always have the option of either molar distalization, or if you use clear aligners, sequential distalization versus extractions of premolars. How do you make those decisions whether you want to distalize teeth or you want to extract the premolar?
Yeah, wow. You know what? That's a very good philosophical question, because really in the in the papers, I mean, I'm not saying the paper, kind of logically it should be the same. I mean, the end result, because you want to somehow move teeth back. Now you're gonna move them back whether you distalize everything or you extract. And some people extract first premolar, some people extract second premolars. I do that a lot. Some people extract actually molars. So I would say that definitely, I would say do not distalize if you have cases that they are more vertical cases. Basically using the Yara bags. If you have a short ramus and you have a vertical component like a big lower gonal angle, I wouldn't distalize. I mean, because that again is difficult to control the extrusion of the molars in those vertical cases, and you can actually end up worse than if you extract in these cases. So that would be the only thing. When you start talking more about low angle cases, brachiocephalic, is when we start in the territory that absolutely we can in some cases distalize. Let's say a little bit of an overjet, brachiocephalic, there's no crowding, it's just sagittal, then you can distalize few millimeters, maybe 2-3. I mean, at least I cannot distalize more than that. And if you need more, some crowding component, other things, then you can start thinking about extractions.
Thank you, Patricia.
Okay. Yes, we have a question from Ute. Hello, Ute, I hope you're well. Antonino, great presentation, but what about any specific mechanics for hyperdivergent patients? Don't you ever use skeletal anchorage devices to prevent molar extrusion?
Yeah, you can do that. And again, I mean, there's always cases that are going to be tough, extremely tough. I mean, as I said, I show one that even if you remove the molars completely just to over-rotate the mandible, it's not going to happen. It's just going to be bad. But there's some cases, and I do believe this, in my opinion, I do believe that, thanks God, we treat, most of our cases are basically within the Bell's curve, the 75%. And they're more class 2, more class 3, but they're still within what we can do with orthodontics. So, and the more you get kind of outside that is when you start getting problems. But skeletal anchorage, it does work, absolutely. And I don't use it very much. I used to do it at some point. For some reason, it's not, I would say, very popular in the last few years in the US. Interestingly, it became popular lately with the tats for the expanders more than any other thing. But yeah, I mean, if you have a case where you actually can do a VTO and you can see how much outer rotation you need, and that will tell you how much intrusion. That's how we used to do it. We used to plan for how much intrusion I needed. Definitely tats can help you to at least control the vertical in the back. There's no question about it. I mean, it can help whether you use that or plate. Yeah.
Peter?
Yeah, one of the challenge of correcting a class 2 malocclusion is to control the proclination of the lower incisors. Now, unfortunately, when you have a class 2 malocclusion, you already have a procline lower incisors. It's kind of like buy one, get one free. That's a challenge. Yeah. So now, if you start out with a procline lower incisors, now obviously you can use brackets that have a negative chalk on the lower incisors. Yeah. Now, you also show a case that you extract upper 5 and run class 3 elastics to retract the lower incisors. Now, is there any other magic on it, secrets about the control of lower incisors that you utilize in your practice that might be helpful to the graduate students?
No, The one thing that I use beside the brackets and the arch wires is, of course, to analyze the space that you need. Where do you want those incisors? And in some cases, a little bit of interproximal reduction. I can tell you this is totally clinically, in my experience, there's nothing that I can put a paper on this. Call a paper because I don't know, but in my experience, after several cases that I have analyzed the before and after, I know that the lower incisors, if there's no crowding, I can upright them with some stripping and power chain. I can upright them easily 5-6 degrees. I've done more than that, but I would say to be very consistent, 6-7 degrees, I can do that. Now, if you have crowding, that's a different, then you have to start adding that you need more space. And at some point, it's just impossible. You're going to end up either flaring them a little bit, or you're going to end up doing some extractions. The thing is, how much flaring are you willing to accept? And I think that's depend on the facial, on the skeletal pattern of the patients. I know that brachycephalic patients, you can cut the incisors in 100-140 degrees, very stable. Without any problems, because I've seen that happening in actually non-treated patients and treated. So if you start getting more dolichocephalic, then you can go beyond vertical. It's going to be even less, 88, 87. So it's all depend on the pattern of the patient.
Okay, Patricia?
Yes, thank you, Peter. I have a question from Pepe Chaques, our friend of the Angle Society of Europe. Pepe, I don't forget you. I can ask the question for now. Besides the possibility, the question is, besides the possibility of a forward position of a point for dentoalveolar reasons, are there true skeletal maxillary prognathism? I had never heard, this is a comment from Pipe, I had never heard of a maxillary setback done in orthodontic surgery. Typical question of Pipe. I love you, Pipe.
Yeah, and you know what? I got to tell you this, me neither, because I'm pretty sure, and I don't work in a hospital, so if somebody is working in a hospital setting with UC syndromes, maybe yes, but in the routine cases over the last, I don't know how many years I've been practicing, I haven't seen really any cases that I can come to my mind where I needed to exactly do that, set back the maxilla. So I think that most of the cases is just the opposite. And I think that the A point is tricky. The A point, but by the way, the A point, that doesn't really exist. We did a research when I was at Penn with the 3D cameras when they start coming where we used to mark the A point on the lateral view, and then when you turn the face, the A point is like here. So the A point that we see in the X-rays and we mark is actually not really when you finish the A point. So the A point can change a lot, can change by the T. So it's completely dentoalveolar point, and so I have to agree with that. I don't see very many cases that I could say, Jesus, I would like to move the maxilla back.
Yeah.
Yeah.
I hope that the Pepe is okay and fine. Thank you. Thank you for your answer. Thank you. Peter, it's to you.
Okay. Now, if patients are not cooperative in wearing class 2 elastics, would you consider using any type of fixed functional appliance for class 2 correction, or would you really prefer using TAD instead, just to resolve that patient compliance issue?
Yeah, you know what? I think that both ways would work if you have somebody who's not compliant. So I think that is based on what people are used to it in clinical practice. I mean, I know many people, and we all do the same. You start using something that you like it, and then it becomes something routine for you, and it might not be a routine for the guy next door, but you feel comfortable with. So I mean, I would say that I'm totally fine with using TAD or class 2 corrector fix, and there are many, and they're all pretty good. I think the only thing that I could say is trying to choose the right patients to do the class 2 correctors, because remember that the class 2 corrector is like a full-time class 2 elastics on steroids, so they will definitely move the molars back maybe a little bit. They will flare the incisors. They will level the occlusal plane. And if you do that on the wrong patient, if it's crowding, if you don't control the lower incisor, if it's a little bit vertical, it might not work very well. Or if the mandible is short, then you're going to be for years trying to correct that, and it's not going to happen. That I think that they can be used too, but depending on how you use them. I mean, that are anchorage. So I mean, if you want to distalize with that, maybe if you do extractions. But I just saw an article published recently where they do a herbs appliance with that. And herbs without that, and my question is, I mean, I don't know. So I mean, why are you anchoring the TAD? I mean, the herb with TAD. I mean, that's really improve. It doesn't improve. Sometimes the articles that you read statistically, they find differences that they are clinically non-significant for me. I mean, do all the effort to gain 2 millimeters. 2 millimeters. They're not going to help me very much in the typical case where we have traveled, you know what I mean? So, but that's just part of the everyday fight that we have.
Yeah. Well, one more question is, we have quite a few graduate students really admire the finishing of your cases.
Thank you.
And they were wondering, how do you settle the posterior occlusion, and what is your retention protocol for class 2 cases?
Do you have a special secret?
No,
for finishing.
Yeah, the secret really is bracket placement. I learned, and Renato can, and Peter, you guys know very well Dr. Larry Andrews. I mean, I learned from him to put the bracket on the FA point by eyes and get the practice to do it. And at the beginning, you have to reposition more. When you get more practice, you just can put the bracket in the right spot very often. And then when you do that and you level the occlusal plane, basically things start getting better. And the 6th key, almost every key has an application to the mechanics. That is, it's not the right time right now to talk about it, but key number 1 to key number 6, we can find an application in the mechanics, in the wire sequence, and the type of wires that we use. We can justify that based on the 6 keys of occlusion. So this is really important.
Renato, may I ask the very last question, please?
How can I say no?
Yes. No? Okay, just your finishing wire. What is your finishing wire? I have a question regarding this one. You have special finishing wire. I saw that it's
well,
a multi-braided wire.
Yeah, it's a multi-braided wire, and that's a wire that is being used for finishing for many people for years. And the reasoning is the following: it's a rectangular wire, stainless steel, that can eventually sort of fill the slot or almost fill the slot. So you can run vertical elastics without having the typical problem that you will roll the teeth in, like Larry Andrews says. Like, I mean, you use vertical elastic from the buccal and the teeth occlude, but they open from the lingual, because you're using round wires or no wires. Some people just put elastic without wires. So final wire has to be rectangular, has to have some flexibility. That's why it's braided. So the teeth can accommodate with the rubber bands. And I use that only for 4 weeks because if you overdo it, then you start paying a price for it too.
And do you ask to your patient to chew chewing gums with this wire?
No, I mean that's the old tweet things that they used to put the holly retainers and chew a lot gums. I don't tell them, but I don't think it will hurt if they do that. I mean, there's no question about that. I mean, you chew and the teeth accommodate. Yeah.
Okay, I finished. I'm sorry, Renato. Very sorry.
No, I'm perfectly fine, Alicia, but you are the queen. I think it's time to stop the webinar. I'm sure that we could continue with questions forever. So thank you very much, Antonino. But it's time now for Eve to close the webinar of today. Eve, please.
Yes, thanks, Renato. Yeah, Antonino, well, thank you on behalf of everybody to have shared this outstanding material and those extremely well-documented cases on class 2 treatments, which are the bread and butter of our orthodontic practices. I would like to thank also our moderators of today, Dr. Patricia Aubach-de-Jean from the Angle Society of Europe and Professor Peter Nine from Angle East. Remember that this week, after Professor O'Brien and Dr. Sandler's excellent lecture yesterday, and after today's superb presentation from Antonino, we are keeping going on with our class 2 treatments. Tomorrow we'll have 2 speakers, Dr. Mauro Cozzani from La Spezia, Italy, former Boston University graduate. He is the only orthodontist to be members of the Angle Society on both sides of the Atlantic. If I recall, he's member of Angle East and the Angle Society of Europe. And Dr. Antonio Manni from Raccale, Italy. Both will talk about herbs treatments, not about the herbs appliance introduced initially by Emil Herbst, the 5th International Dental Congress in 1909 in Berlin, neither the one later modified and improved in the late 70s by Hans Panchers in Gießen, and inviting you to attend tomorrow's